Hello, I'm going to present to you the video version of Evolubloc, the educational training resource for ALR with its Evolubloc method, or how to learn to train trainers using a step-by-step method. Each step will be illustrated by a practical workshop, which you will find in this video after a brief theoretical introduction to the methodology. These resources are free. You can use them for your training sessions as long as you respect the spirit of sharing knowledge with as many people as possible. Please do not alter them or use them for purposes other than intended. They are available for free on the Surge Hub platform by following the link below in the description, or on the Evolubloc smartphone app, which is available for free on Google Play or the Apple Store. For any information regarding courses in Paris or sessions abroad, I invite you to visit our website www.adral.fr and send me a message via the contact form. Let's go, we're off for a good hour and a half of video. Welcome to the operating room for the first practical workshop, which involves illustrating your sonoanatomy landmarks. Naturally, we will begin with the axillary block, which is often considered the initial approach for beginners. I will demonstrate how to identify the sonoanatomy elements that we encounter each time and upon which we will depend for the successful execution of your procedure. The selected anatomical landmarks are straightforward. Consequently, for the axillary block, you have the epidermis, the humerus, which is particularly important, the tendon of the latissimus dorsi, which you truly need to endeavor to put into perspective, and subsequently the artery. When we discuss sonoanatomy, we are specifically referring to these particular elements. There is absolutely no necessity for anything beyond these. These three essential elements are entirely sufficient to execute your block procedure safely and with the utmost efficiency. We concentrate primarily in connection to the artery and quite frequently between the biceps muscle and the coracobrachialis muscle, the musculocutaneous nerve. At this particular level, we discover the median nerve, a nerve typically situated on the opposite side of the artery. And why do we emphasize the latissimus dorsi muscle? Because at that particular level, the radial nerve, which might be somewhat challenging for beginners, is actually quite straightforward. It's somewhat similar to, those divining rods used to detect things. They are oriented in different axes. So with merely one singular probe axis, it's difficult to have all four nerves in the identical plane. All right, so here we have it, all right? These are the straightforward and fundamental components. However, it is absolutely crucial before you commence practicing your axillary block. That is the concept of sonoanatomy. It is not exceedingly more complex than that, but it genuinely involves selecting your fixed elements that will enable you to identify the anatomical variations of the various nerves to ensure an effective block, and, in any case, practice safely. Therefore, we are able to proceed immediately. With the complements situated at the elbow, these complements are essentially trunk blocks that will enable you to accomplish, for instance, extended analgesia in painful surgical procedures, or simply to conclude and attain maximum effectiveness. It is quite possible that initially, due to the various orientations of the nerves, you might not have observed a nerve distinctly. Do not panic, just proceed. Execute the complement at the elbow, the position remains unchanged, and you will achieve 100% effectiveness. It is very crucial to be familiar with them because they assure you a comprehensive beginning to your learning experience. Additionally, ensure that you demonstrate it to your learners or trainers, as these are compact blocks that can be immensely beneficial. Following this, we have the elbow complement of a median nerve block. It's quite straightforward. You position the probe approximately at the level of the elbow crease, and the primary landmark will be the artery. And the median nerve is nearly always adjacent to its artery at that particular level. Thus, you see, truly it's something quite straightforward there's no necessity to learn all the muscles and every detail at the very outset, as that will probably lead to confusion and hinder you from progressing to practice and commencing. Of course, as you gain experience, you can gradually learn the names of the muscles and all that, knowing that your main landmark is the artery and that the median nerve is almost always there, even in small children, babies, spastic individuals, and so on. It's really an anatomical ultrasound feature that we find every time. A very helpful addition is the radial, as I mentioned earlier. We rebuild the skin, the radial nerve. Here you have the humerus bone, and subsequently it appears like this. Forms somewhat like elongated droplets. That is the radial nerve. So there it is. Mastering sonoanatomy means getting good at its detailed diagrams. But why draw them? Because when we observe a learner who confidently sketches their landmarks without any hesitation, we understand they have comprehended and fully integrated them. And when, for instance, you are preparing to demonstrate a block to another individual, even if they are not a novice, even if they possess expertise, the initial step is to create a concise sketch, a brief diagram for them. With the elements you have selected that you consistently practice, you quickly comprehend how to convey this concept to someone who will also practice it. So that's truly significant. The third small addition to complete your axillary block is the ulnar nerve at the elbow. Now this is quite straightforward. Nonetheless, it is situated slightly beneath the elbow crease at the lunar level. You have the skin, and there is this muscle here that is rounded at that specific level, which is the flexor carpi ulnaris, FCU. In a comparable manner, it is not entirely essential to memorize these specific names. The nerve is consistently positioned. At the uppermost section of this specific muscle, consequently, you have three distinct components in relation to the elbow, along with the axillary block, which will allow you, right from the very start of your educational journey, to achieve the maximum efficiency of 100%. Therefore, we will swiftly move on to the other two important primary blocks of the upper limb, which are the interscalene block and the supraclavicular block. Therefore, concerning the interscalene block, let us proceed further. Once more, the epidermis. You possess these two muscles situated beneath, which are identified as the sternocleidomastoid and the trapezius, correct? The principal landmark for the interscalene block is the scalene muscles. Consequently, my primary landmark is the anterior scalene muscle and the middle scalene muscle. Thus, the block in question is the interscalene block, and you will locate your brachial plexus along with your C5 nerve roots. And C6. Often C6 has a bilobed appearance, but you will see that later, when you unfold the plexus a little, it can also appear bilobed. So what is quite important is that even when you have this image, make sure to check a few centimeters by slightly moving your probe to verify that there isn't an anatomical variation and that C5 is not actually here and what you thought was C5 wasn't C6. Otherwise, you will have an incomplete block, okay? I am presenting a concept that is not yet incorporated in the current edition of the book. When we talk about superficial cervical blocks in their intermediate section, it entails a small injection situated in this area, all right? It is positioned between the muscular plane and the scalene plane, understood? I will not insist because in this specific version, we have embraced the interscalene block in a truly traditional manner. To wrap up our discussion on upper extremity blocks, we have the supraclavicular block. I approach it in a truncular manner, somewhat similar to a Bisbes method. You have additional descriptions, which I've incorporated in the book and in the posters, using the traditional form, with the probe positioned truly parallel to the clavicle. However, here I will demonstrate it to you with a slight angle, akin to a bis. It will be more of a bis-bas approach, utilizing the truncular method. Alright, so we identify a few of the similar elements, as it is the supraclavicular block utilizing a truncular approach. We perform approximately the same procedure since it is typically the continuation of the bis-bas method. So we will redraw slightly I might make it somewhat smaller. The sternocleidomastoid muscle, the trapezius muscle, all right? We will have the middle scalene muscle. It will be different because we took a slightly different section. So always our anterior scalene muscle. Our middle scalene muscle is indeed present. And so in this particular anatomical region, we will have the upper trunk, which generally corresponds to the C5, C6 nerve roots, the middle trunk, approximately C7, and here the lower trunk, which corresponds roughly to C8D1. In this specific area, you will find the first rib, the clavicle, and then the pleura, along with the supraclavicular artery. I really like this approach because the artery is a bit more exposed, and especially we have this component of the lower trunk that is often missing in the classic approach. So it seems like the block works when we test at the elbow and all that, but in reality, very often the posterior or anterior component is already crossed over, already gone, and we don't have good effectiveness. Personally, I prefer this trunk approach, which can actually be combined, but we'll see that a bit in different explanations with a PEX block or with the intercostobrachial to really create a block that allows you to perform all upper limb surgery. And why not? If in major traumas there's involvement of the inner aspect of the axillary hollow, you can combine it with a diaphragmatic intercostal block. So here are the essential foundational blocks of the upper limb. Now, let's seamlessly transition to the primary blocks of the lower limb. We shall naturally commence with the femoral nerve block. The sonoanatomy landmarks comprehensively encompass the femoral region, including the skin layer, the artery, and you typically observe the nerve in this manner, which may possess two smaller components alongside the genitofemoral nerve, the artery, and its accompanying vein. Okay. These are the crucial foundational landmarks to thoroughly understand and effectively approach a femoral nerve block. Additionally, you might incorporate the femur and the iliopsoas muscles along with similar components. The second most highly significant and crucially important block in the lower extremity is the sciatic nerve block. Consequently, I will comprehensively demonstrate to you the sonoanatomy components situated at the subgluteal region. Sciatic nerve. At the subgluteal level. Very often it is a nerve that is more superficial than we think. It is located approximately between 4 and 6 centimeters, whereas when approached a little lower, it can go deeper. Consequently, the primary anatomical landmarks are consistently the dermal layer, the gluteal muscle, the femur bone, and the ischium. Is that correct? Thus, this encompasses the gluteal region, the femur bone, the ischium, and at this specific subgluteal level, the sciatic nerve frequently exhibits this particular type of appearance. Here we possess the sciatic nerves. As we advance further downwards and continue with an approach at the popliteal level, we will encounter the classic description of the sciatic block at this specific popliteal level. The primary elements of sonoanatomy will be the popliteal artery along with the dermal layer, but especially there, the popliteal artery stands out prominently. At this level, the nerve will bifurcate, and occasionally you can observe it with the fibular and tibial components. The popliteal artery is essential, and we can utilize this diagram to indicate that if an IPAC is necessary, the injection will be administered precisely here. Consequently, these are the fundamental sonoanatomy components necessary for an approach to the sciatic nerve block at the popliteal level. Allow me to illustrate the final block for you, which is the iliofacial block through the suprainguinal approach, known as the BIF-C. This technique truly possesses an extraordinary potential for all types of painful surgical procedures, whether they involve the knee or the femoral neck region. It can be utilized for providing analgesia and it can also serve as an anesthesia block for any surgical operation on the lower limb when combined with a sciatic block. Certainly, so within this particular region as well, the anatomical landmarks and the skin, all right? You have the anterior superior iliac spine, the extensive iliacus muscle situated here, and your main anatomical landmark will be the small circumflex artery, especially the deep circumflex iliac artery, all right? And so at this point, we have the sonoanatomy of a suprainguinal iliofacial block, all right? Therefore, you can clearly observe that these are the essential elements. Here you have the muscle structure like this, and at this particular level, you possess the conclusion, if you will, of the diagram where the intestines are situated at this particular level. Thus, here are all the essential components of practical workshop number 1 that you must undertake to educate yourself or to instruct others, ensuring that you can confirm that once they have thoroughly assimilated all these concepts, they are capable of transmitting them effectively. The final segment of this practical sonoanatomy workshop necessitates sketching your anatomical landmarks, specifically focusing on the diffusion blocks. Consequently, we shall begin with the diagram. The diagram starts with the outermost layer, the skin. Frequently, there tends to be some confusion regarding the pedicle, but nevertheless, you have an initial muscle, which is the external oblique. A subsequent muscle, the internal oblique, followed by the final muscle, the transverse abdominis muscle. Mobile formations, which are essentially the loops of the intestines, all right? So what I recommend to you is that in diffusion blocks, you should aim for the second to last structure. This means instead of counting 1, 2, 3, begin counting from here. You know it's the peritoneal cavity, so count in reverse like 3, 2, 1, and you will understand that the target space will be at the second to last structure. This is something we will always find a little bit in the different diffusion blocks. Think about the second to last structure, but start from the inside. This will prevent confusion, because sometimes a pedicle is said to be small or presents itself a bit like this, and it's hard to tell if we count 1 or 2, whether the patient is too corpulent or, on the contrary, very thin. This is the initial block, a block that is relatively straightforward to memorize. The challenge will primarily lie in the positioning of the probe to ensure optimal effectiveness. Consequently, its effectiveness will be contingent upon where you execute it, which is somewhat typical of diffusion blocks. They are relatively easier to memorize, yet perhaps more challenging to systematically organize and automate in order to achieve complete and absolute effectiveness. The second very important block is the PEX series, which is somewhat similar in nature. We take into account the anatomical structures in this specific manner. You have the ribs present. This particular structure, which is a mobile hyperechoic region, is undoubtedly a no-go zone, known as the pleura. We will also incorporate the skin, as previously mentioned, the series of pectoral muscles, like this, with an initial muscle being the major pectoral and a subsequent muscle being the minor pectoral. As I previously mentioned, there exists a minor variation here. However, it remains the penultimate and the second injection for PEX 2. Here you have the detailed description of the sonoanatomy of the PEX diffusion block, utilizing a somewhat lateral approach. If we take a slightly more medial approach, especially at the medioclavicular level, we'll see almost the same pattern as in the paravertebral block. So we'll continue with the paravertebral block, correct? In this context, it is quite similar, but rather than ribs, it involves the transverse processes, as illustrated in the diagram. You can observe that the anatomical region is straightforward, yet it is crucial because it signifies the fundamental common aspect to comprehend. In this part, we see the bone structure, pleura, and the no-go zone, which looks a bit hyperechoic. We also have the intercostal traumatic ligament, though I can't remember its exact name now. But it's not crucial, as I'll note it next to the diagram, showing we can practice without memorizing every detail. The intervertebral muscles. So, it's the same. Depending on the level where you are going to puncture, the nomenclature and the names of the muscles will change. But really, what's important? What is crucial is that in a paravertebral block, your specific site, your precise target, is located here. Therefore, we can deconstruct it as follows. This is the sonoanatomy. Here are the interspinal muscles. Here is the ligament. And these are the transverse processes. These are approximately the same anatomical landmarks as the erector spinae blocks, except that the target will make contact with the bone here, and then the mites will be positioned here. A singular, all-encompassing description that includes 3 distinct types of blocks. It remains consistently unchanged, so you have the erector spinae, and more specifically, the erector spinae block. There you have it. This brings to a close this foundational workshop number 1, whether it is to commence a block you have not previously executed or to educate a block to a colleague, a learner, and subsequently to verify if they have understood this essential initial step before being able to progress to step number 2. The practical workshop number 2, which corresponds to the second step of the Evolubloc method, involves acquiring the skill to recognize a specific area and becoming familiar with positioning its image precisely at the center of the screen. This includes being able to move it and, most importantly, to dynamically follow this structure. Therefore, you take your ultrasound device, which is something you can easily do on your own forearm or on yourself. Alternatively, you can also practice on a volunteer. You position your ultrasound probe centrally on the forearm and search for an image that corresponds to a nerve. At this point, we observe that directly in the center, there exists a heterogeneous image featuring a delicate white line, somewhat resembling a honeycomb structure. This is indeed the quintessential appearance of a nerve when viewed through ultrasound imaging. Therefore, you must become accustomed to recognizing and selecting the optimal image through subtle tilting adjustments. You may also enjoy experimenting with horizontalizing or verticalizing the image. Most importantly, in your everyday practice, it is crucial to be capable of dynamically following this structure. The workshop fundamentally involves meticulously following the structure and ensuring it remains centered on the screen. This is precisely what you will consistently do each day in your practice of ALR blocks. You accurately identify the structure, and here we have it distinctly. Subsequently, you accurately position it in the correct manner. Occasionally, you may even need to bring it slightly nearer to the edge of the screen to achieve a more concise needle path. Most importantly, in the practice of ultrasound, the essential aspect is to be capable of following it proficiently. This will enable you to differentiate between fascia or tendons on certain occasions. Additionally, here you observe that we have a small structure that is likewise hyperechoic with a bright white line. By applying slight pressure on the probe, you notice it collapses, indicating it's a vessel. All right? So learn to master the probe, follow that, spend a little quarter of an hour on it. It will allow you to acquire mastery of the image, the manipulation of the probe, and the optimal positioning of the nerve right in the middle of the screen. The practical workshop of the third step, from my viewpoint, is one of the most significant workshops. And interestingly enough, it is something that is genuinely not documented anywhere. Therefore, the interest lies in selecting the function point and subsequently the visualization of the needle, which occasionally presents a slight challenge for the learner at the very beginning. Certainly, one of the relatively straightforward methods to conduct this particular workshop is by utilizing simulation phantoms, which are quite expensive in the marketplace and are accessible through specific partners. These phantoms have the minor drawback of leaving imprints in the gelatin blocks. Alternatively, although I am not particularly fond of wastage, you can, on occasion, especially if you are conducting a demonstration or training session for approximately 10 individuals, opt for a piece of meat. It should be the most affordable option available, yet it should still contain some meat and ideally some fascia and a bone as well. Here I selected the end of a pork ham, but you could alternatively choose a small goat leg or even a turkey leg. So the 3 exercises you are able to perform are as follows. First, learning to puncture while maintaining control of the needle, which constitutes the initial exercise. The second exercise involves locating your needle when it has been misplaced, because in real-life scenarios, we are frequently very focused on our screen, and we might apply excessive pressure on the probe and the needle, which often results in losing the visualization of the needle. And subsequently, the third exercise entails modifying the orientation while sustaining visual control. The puncture point is an exceedingly significant concept, as you understand from what we've just discussed. It is that in order to visualize the needle effectively, you should endeavor to maintain it as parallel to the probe as feasibly possible. In that scenario, you can distinctly observe that the probe emits signals and records them. When the needle is precisely parallel to the probe, you will obtain an image similar to this. When the needle is positioned in a perfectly horizontal manner, you achieve the maximum signal, thereby providing the optimal opportunity to visualize your needle. Additionally, it is essential to comprehend that when you slightly tilt the probe to obtain the best possible image, you should avoid puncturing directly in the center. Instead, make a slight shift, as the ultrasound functions in such a way that the maximum signal is concentrated in the center. Therefore, you will need to make a slight adjustment to the puncture point to achieve a perfect visualization of your needle. The other notion is the greater the angle, the less you will see the needle. Beyond 40 degrees, you will completely lose sight of the needle. So that's a bit of the problem when you are doing, for example, deep blocks. Often we notice beginners are executing it in this particular way. Do not hesitate to erase and adjust your function point to ensure that as the needle progresses within your patient, it remains parallel. Consequently, indeed, choosing the function point and visualizing the needle is arguably the most essential workshop before starting your blocks. To keep things straightforward, ensure you position yourself correctly and take a comprehensive look at your patient, okay? You will notice a distinctly classic muscular region accompanied by fascia. Afterward, you choose your function point. Now, look closely. Here, I have my probe, which is quite perpendicular to the axis. We'll place it roughly here. And then you see that naturally the needle appears. So this is the first exercise, which means operating under visual control. The benefit is precisely to avoid structures that might be vulnerable to another vessel or a nerve. The second exercise that you must learn to master thoroughly before beginning on the patients themselves, all right? So here we are going to leave the needle. As I was mentioning to you initially, we are quite tense, we apply tension, we are focused and all that, and we lose the needle. So take a deep breath and relax a little bit. You can effortlessly leave the needle in its position, just as I have done. There, it is a simulation exercise, yet it is remarkably close to real-life scenarios. Then you perform a small sweeping motion in this manner, and suddenly you observe your needle reappear. It may not be perfectly parallel, but you see the most crucial aspect is, you notice I had turned slightly and I realigned myself properly in the axis, somewhat like when performing a vascular puncture. You really need to see where the needle is going and then position your probe to retrieve it. So the exercise is very simple. You carefully watch the direction of the needle and make a slight tilting motion like this, and you retrieve your image. Relax. You capture the image, relax, and capture the image again. This is really something that will be useful to you, and you need to learn to master it. The third small exercise, once you have mastered the function point and the visualization of the needle, is when, for example, you are going to do an axillary block. You have seen a single function point, but need to address 2 or 3 nerves. Alter the orientation and subsequently reorient while maintaining the target. So indeed, I don't have any nerves present here, but let's envision that under visual supervision, that's truly the advantage and contribution in terms of the safety of the ultrasound in comparison to neurostimulation and numerous other methods. But then we retrieve the needle. So let's imagine, for instance, that we intend to proceed here, and then afterward, well, under visual supervision, we continue. There we go. You withdraw your needle. Okay, and then you advance it, there you go. So
You observe I've slightly lost alignment, perhaps I'm not entirely aligned, so I perform a minor adjustment, and let's envision, for instance, we're executing a pectoral block or something similar. Well, that was my intended target, and then imagine you're performing a pectoral 1 and a pectoral 2. It's quite straightforward to learn how to accomplish that under controlled conditions. I withdraw slightly, adjust the angle, I lose it, then I reposition, just as in real life scenarios. You can engage in small practical workshops, and you observe I'm encountering a bit of difficulty because I took a slight orientation, so I redo it, and then I proceed a little here, for instance, right here. So if I had, you observe these small tilting movements and such. So a really important piece of advice: when you lose track, don't move both at the same time, because when you move both at the same time, you're completely off. You don't know what you're doing, and that's often what we see with beginners. So we can do another nerve. There you go, you see there perfectly. And also keep in mind that as long as you are not injecting, the needle is in place and you are not at risk. You don't need to aspirate since you are not injecting. So you can absolutely let go of your hand, relax a little, and keep that hand steady and well positioned. Concretely, that's what I would do on a patient by placing my wrist to stabilize the image. And subsequently, there you proceed, resuming the visualization of your needle, and then you have the ability to adjust your orientation accordingly. We can envision that we had an air slightly elevated, and then there you proceed, that was it, there you proceed. So what is important similarly, you see I put myself in a little bit of difficulty with the angulation. Well, here, this was my target. So there you go, this workshop, the function point, the visualization of the needle. Take some time, spend 30 minutes each to learn to visualize. It's really very important. You cannot start à la Corrège in ultrasound if you do not master this. All right? See you soon. Practical workshop number 4 therefore consists of aligning. What we saw in workshop number 1, that is the elements of sonoanatomy, nerve recognition, including the structures and their dynamic characteristics. With ultrasound imaging and step number 3, the choice of the puncture site and visualization of the needle. So here, of course, this is workshop number 4. We will review the different limbs, the various blocks of the upper limb, the lower limb, and then the diffusion blocks. So let's start with the axillary block. So as you can see, I position myself. Like this, I take the patient's arm a little onto myself. My right hand is stable and fixed, slightly stabilized on the wrist so as not to move my image. And I start to scan and follow. Here we see a slight anatomical variation, but it more or less matches up. So to be a bit more didactic, we'll do it this way. So you see the main landmarks we saw earlier, namely the bone and the skin. The tendon of the latissimus dorsi, so as I was saying, to put things into perspective, the radial nerve, which is always located above at this level, and then the musculocutaneous nerve. Now you can see that the more characteristic image would be to have the musculocutaneous nerve between the biceps and the coracobrachialis. Well, this is part of anatomical variations. In a significant number of cases, as you can see, it gets closer to the median nerve. Once again, we can identify the elements from step 1, namely the musculocutaneous nerve, which is clearly visible right here, and the median nerve. The radial nerve, and then when we tilt the probe just a little and follow dynamically, we can clearly see the anisotropy. Anisotropy is a concept I forgot to mention to you earlier. In fact, during the dynamic tracking of the nerve retains its properties, keeps its nerve shape. This is precisely what distinguishes it from a fascia or a tendon. So workshop number 4, do it on a volunteer, and then you spend about 15 minutes on each nerve, and then you practice identifying the elements we've seen and memorized. You follow the nerve bundles dynamically to make sure they are the intended anatomical structures. There is no need for neurostimulation. You know, the median nerve is clearly visible in this position. And if we keep following it dynamically, it will curve around the artery. So that's it for the artery, and that concludes the procedure for the ultrasound-guided axillary brachial plexus block. We're going to take advantage of this position with the additions at the elbow. Now, this is very important and very interesting. I'm going to take my gel, simply because you keep the same position. You take the line of the elbow and you place your probe.
So here, as you can see, it's the same as before. You need to reduce a little to focus and optimize your image. We can see the artery here with the median nerve. It's a bit like the image we had earlier. You see the artery and the median nerve. To focus a little, I have a new ultrasound machine. There you go, like this. And you can find the image of the artery accompanied by a median nerve. The puncture will be done in this direction. Now look here, I'm taking a slightly wider field, just a bit more. And I rotate 180 degrees. And I get back my image of the radial nerve that we saw in step 1 with the humerus. And then this little image shaped like this. And so I can do an additional injection at the elbow. Basically, when you start your axillary blocks, it's not very easy. You perform your block at the axillary level. And then if there's one of the structures you didn't see clearly, you keep the position and inject 3 to 4 cc. For the additional injection at the elbow, we'll take this opportunity to show you the last one, and all of this will really help you achieve 100% success at the beginning. So I told you about this big muscle here, the FCU, okay? So you position yourself a little bit at a good spot. 9 to 10 centimeters here, okay? And then you place your probe like this, and as you can see, we find exactly the same image as earlier. All right? You just need to enhance it with the ulnar nerve, which is at the top. So this is actually quite common. It's almost always the case. With this image, there are very few anatomical variations at this level, and it allows you to achieve a 100% success rate with your nerves. With your blocks, sorry. There you go. So here we clearly see the elements we looked at right at the beginning. So we'll move right along to the upper limb blocks, starting with the interscalene block. For the interscalene block, it's the same. It's quite simple. You start from the clavicle. So you place your probe against the clavicle and move upwards. Okay? All right, well here it's really, we're live, you see there it is. So we use the landmarks that we saw right at the beginning. The anterior scalene, okay? The middle scalene. Here we have the sternocleidomastoid. And so as you follow along a bit, you see here we have a slightly unusual configuration again with, there you go, C5 and C6, all right? So by narrowing the field, we'll get better resolution. There you go, C5, C6, we find the anterior scalene, the middle scalene, okay? I haven't talked to you about the superficial cervical block, but if you had to do it, here you can see the long thoracic nerve wandering a bit through the middle scalene, which explains why it's always important to inject within the field, because if you're out of the field, you could easily hit it. This structure, so if you had to perform a superficial cervical block, it is this specific layer of fascia located right here, into which you carefully administer an injection of a few cubic centimeters to effectively reach and anesthetize the clavicle area, a relatively small and specific portion of the labrum, and the acromioclavicular joint. If you want to perform a regional anesthesia procedure, a shoulder surgery under pure regional anesthesia. The supraclavicular block, so as I mentioned to you, you have the classic description, which I don't really like, with our first rib, the clavicle, and the pleura underneath, and then the artery. The problem quite often is the inferior trunk. And the inferior trunk, sometimes you see it has already crossed over. So I prefer this approach, which corresponds to a trunk approach, or the bispes, if you will, with the superior trunk here. As an observer, I'm very close to the screen, so maybe you can't see it, but it's the superior trunk, which would correspond to C5, C6, which would be the bis. The middle trunk, which would roughly correspond to C7, and here you can see it perfectly, that's it. That's your target, to be 100% effective. So there are several reasons. First, we push the artery a little further away. Then we're sure to get both the anterior and posterior components of the inferior trunk. And that's often what's missing. When you do the pocket corner, or when you use the classic supraclavicular approach, and then you have the superior trunk. Now, what's also important is that you can combine this block, for example, with a PEX. So why a PEX 2? Why a PEX? Simply because you can cover part of the intercostobrachial nerves. Well, these are actually fairly recent concepts. I won't dwell on that, but you can ask me in the comments or through the contact forms. What I meant by that is a bit complicated to explain to you right now. But for example, with this trunk level supraclavicular approach, here you can clearly see the anterior scalene, the middle scalene, the superior trunk, the middle trunk, and the inferior trunk. It allows you to perform all surgeries of the upper limb. And if you see that it affects the clavicle a little, you just add 3 cubic centimeters with the same puncture point. And then if you feel that you need to cover the inside of the axillary hollow and the intercostobrachial nerves, which is more of a thoracic component, right after that you can do a PEX. For PEX, you place your probe parallel to the clavicle, then you slide it, and you can see, well, here it is, you can see very clearly. You see the bony processes here. There's a small artery, which will be the axillary artery, and then you have the injection with the minor pectoralis and the major pectoralis. You can see the small arteries, so we have PEX 1, and then the 2 injections for PEX 1 and PEX 2. And then, if you go a little further into the axillary hollow, it starts with the beginning of the serratus. So these are diffusion blocks. We're not going to talk about them here, but these are blocks that are quite easy to identify, but their effectiveness really depends on the position of the injection site and the number of punctures. In your workshop, you can easily practice on a volunteer, spending 15 to 20 minutes on each block, the upper limb blocks, to help you learn to recognize all the structures. The interscalene block, the single nerve block at the elbow, the supraclavicular block, and then the PEX block. The same goes for the workshop. You can also practice the sciatic block on a volunteer. So for the sciatic block, using the subgluteal approach, you place the probe. Here, it's a bit on the external side. And you can see here that we have a perfect image of what we saw earlier with the appearance of the sciatic nerve. So there you go, we can position it very well. Actually, there's only, at the subgluteal level, it's not that far. Well, here, Sam is particularly slim and thin, but generally, it's about 4 centimeters deep. So we have the characteristic image of the sonoanatomy element from step number 2. So just like we did with the nerves in the forearm, we can also very well do a workshop on this. And as you can see, we're following the nerve, right? And here we're going to follow the sciatic nerve along its path between the buttock and then the popliteal fossa. And so here you can see its appearance. You notice that it starts to split. So we find the somewhat traditional aspect of approaching the sciatic nerve via the popliteal root. So you see that here, at this level, you have the sciatic nerve dividing into 2, the artery and then the condyles. If you want to do an IPAC, I absolutely did not include this type of block in this version of the book. But the IPAC would be an injection under the artery, under the popliteal artery. It would be at this level along the condyles. So that's it for the sciatic block. You see, remember this image, the sciatic block via the subgluteal approach. So now we're going to turn around and do the femoral block and the block, the BIPSI, the iliofascial block via the suprainguinal approach, and we'll finish with the table. So now we're going to move on to the practical workshop for the femoral nerve block. You see the position of the probe as always. My landmark on the outer side and my hand firmly stable on the patient. We've seen a little bit, we can identify the anatomical structures, and we can rock the probe a bit to see everything. My main landmark is therefore the femoral artery. You can see here, right next to it, the vein, which I kind of forgot to draw earlier, and right next to that, the femoral nerve here. So there you have it. This is one of the simplest blocks. This is something you can do at a somewhat beginner level, but of course, once you master the visualization, here you see a slightly better image. When you're steady and have the right view, don't hesitate to make small tilting or slight rotational movements to optimize it. And then bring your puncture point a bit closer, just like we saw by translating your hand. My puncture point comes in from here, so my probe comes in from here, and my target is the femoral nerve. I'm taking advantage of this position to show you the iliac fascia block via the suprainguinal approach. Your main landmarks will be the anterior superior iliac spine, the pubic symphysis, and then at the outer third, it's often a little bit. So here I've passed. Oops, now I have too much. All right, there we go now. And as you can clearly see, your landmarks are positioned right here. So this perfectly aligns with the anatomical diagram we discussed earlier. I currently have a bit too much gain in the depth, so you can manually adjust these settings there, though maybe that is not quite enough. I really hope you can see everything quite clearly on the screen. There, I will add just a bit more depth to the image. There we go, that looks much better now. To show you. So my main landmark is the circumflex artery. Now, in his case, in Sam's case, we can see it very, very clearly. And then we have the large iliac muscle coming in, so that's really the typical description. And then the anterior superior iliac spine. So you come in from here, and I recommend injecting a little bit below the fascia in order to make the circumflex artery rise, and you'll have the product spreading up to the femoral nerves. So let me remind you that the suprainguinal approach to the iliofascial block is an exceptional block for all lower limb surgeries, especially knee surgery and femoral neck surgery, and all of that. And it covers the 3 blocks, the 3 nerves, so it's the famous 3-in-1 Winnie, but adapted for ultrasound guidance. And your main landmark is the artery, cycloconflex artery. So it covers the femoral nerve, right? The nerve. Obturator nerve and the lateral cutaneous nerve of the thigh. So get familiar with this block. It's one of the most promising blocks and currently provides the most benefit. So we're going to cover the last 2 blocks. We'll get set up again a bit for the tap block and the paravertebral block. And with that, we'll have finished this workshop covering the 9 blocks. The main ones, namely the 3 blocks for the upper limb, the 3 blocks for the lower limb, and 3 diffusion blocks, which allow you to perform about 95% of your practice in anesthesia. Regional anesthesia. So the tap block, so that's one of the blocks that is both the easiest to identify because the sonoanatomy is really very simple and well known, and to achieve maximum clinical effectiveness, which in my opinion is actually quite complicated, because the effectiveness of your block really depends on where you position your probe. So the classic description is this. You place the probe here, like this, and then you get the image. Move it a little bit. Now this is characteristic. You have the 3 layers, the intestines moving here, the transversus, the internal oblique, and the external oblique. So a tap block is that. Afterwards, your effectiveness will depend on where you position your probe. A little tip. Sometimes in slightly overweight patients or those with a fatty pad, counting the layers can be a bit difficult. I recommend starting from the inside with the intestines. The intestines are easy to recognize because they move. And then you'll know that your tap block is the second to last layer. So you can even see here, with the device's resolution, the small branches that are between the internal oblique and the transversus abdominis. So your target for diffusion is here. So start from the inside and don't go 1, 2, 3, but rather go 3, 2, 1, and then your diffusion site will be between the second to last structure. This sometimes helps avoid confusing it with a layer of fat. The last block we're going to look at, and that you need to practice, is a slightly more complicated block, really reserved for experts, or at least it has a somewhat longer learning curve. You really need to master the easy blocks first. Axillary blocks, femoral block, sciatic block. After that, move on to a higher level to more advanced blocks. A bit more intermediate, like the PEX blocks, the supraclavicular block, which isn't that easy, the iliofascial block via the suprainguinal approach, which can be classified as an intermediate block before tackling the paravertebral blocks. Quite simply because the angulation is greater. You are very close to the intervertebral foramina and also to the pleura. But it's a block that is extremely effective with an efficacy as significant as an epidural. Whether it's for thoracic procedures using paravertebral blocks or for colonic and digestive surgery with paravertebral blocks, either unilateral or bilateral. A little bit lower down. So we're going to position ourselves. Actually, I position myself as if I were doing an epidural. I do it with the patient sitting because I am more comfortable, but you can absolutely do them with the patient lying on their side in the lateral decubitus position. Personally, I'm more comfortable with the patient sitting. Generally, I do them on an awake patient to go faster. And above all, to have a better view of my needle and the area where I'm going to operate. So let's get set up. And then we'll show you this last block. Here it is, the last block in this series from the practical workshop, step number 4, the paravertebral block with its variation, the erector spinae block. So as I told you, I do it with the patient sitting, okay? And then so we move a little like this, and then we find the image. There you go. So here we have exactly the transverse processes.
And you see, as I move a little, the pleura is here. And so the injection site for a paravertebral block is at this level. It's this little triangle under the ligament, okay? Intercostal transverse. I can't quite remember exactly what it's called. It's this one, and that's the injection site. It's there, and you should see your pleura collapsing, so your needle. You can approach it from here, or you can angle it a bit like this, so you're less bothered by the transverse processes. And as you can see, we find the same outline as at the beginning with the two bony processes. And then the muscles, which are between the two bony landmarks, and can have different names depending on the level you're at. Strictly speaking, it's mainly this aspect of sonoanatomy that's important, and the injection site. So you see like this. Now a small clarification. This is the paravertebral block. At this level, it's the mid block. And here you have an erector spinae block in contact with the apophysis. So this is really the most effective. But sometimes it's a slightly tricky block, a bit deeper. We're getting close to structures, but it covers the entire surgery. Thoracoabdominal surgery, the ESP block, the erector block. Spinae is a very good block, for example, in cases of trauma to the wall, or for instance, for acute lumbago. And with all that, you reach only the bone and you inject the paravertebral at this level. It's still the most effective block, but it requires a bit more expertise. And here you have roughly the visualization. Again, this raises questions about the level of punctures, the number of punctures, single or double punctures, unilateral or bilateral punctures. It depends a bit on your surgery, but here I refer you to all the more comprehensive manuals or websites that discuss this. They explain it much better than I do. There you go, we finished with this workshop. Workshop number 5 corresponds precisely to step 5 of Evolubloc, which is ergodynamics. It is also a fundamental concept. You need to allocate some time to contemplate the organization, how to position yourself effectively, and how to integrate an ultrasound machine into your environment. Consider a space. Position the display screen in relation to the patient. Attempt to organize in such a way that you have everything accessible at hand. Here you observe, I have a cart with all the medications and syringes within easy reach. Here are my syringes, disinfectants, compresses, my syringe thoroughly prepared, and everything else that is necessary. The second thing is to use both hands for the injection. That is very important as well. Personally, I always choose to inject on the side that corresponds to this mark. You can change it, but it's a bit absurd to impose additional constraints on yourself. And I position my right hand on the patient. This method allows my left hand to remain free to hold my syringe, grasp disinfectant, dispose of my compresses into the trash, the waste container, the disinfectants, and all those items. Therefore, step number 5, ergonomics. Frequently, I observe individuals administering injections with their arms crossed, turning around, or not fully aware of their positioning. As I mentioned earlier, I personally ensure to inject from the side of the probe marker, which directly corresponds to the screen. To help you visualize, the screen corresponds to an ultrasound display. So when I insert the needle on the side of the probe mark, the needle will always appear. And if I perform a block on the contralateral side, I turn my probe, use my other hand to insert the needle, imagining I'm on the other side, like this. I use my other hand, and the needle will always appear on the same side of the screen. It seems like a small detail, but when you're starting out, it's a bit complicated. Moreover, if the patient isn't very echogenic, reversing the images, especially in interscalene or similar cases, can be challenging. So get into the habit of always doing the same thing. Always puncture and start puncturing tomorrow. This will give you the same images every time. So really the fundamental step and workshop is ergonomics. Well, there is additionally a rather straightforward method to observe, which is to genuinely visit the various internship locations to witness how the different teams have fully embraced their established routines. Choose for yourself, adapt to your environment, at home, in operating rooms. There's no absolute rule. You can place the screen here or on the other side. You can sit down, that's almost a personal constant. Above all, try using both hands. Following this, carefully observe the detailed demonstrations conducted by experienced professionals, those who are actively involved in the practice. Importantly, this will constitute the final step of the 5 comprehensive steps of the Evolubloc methodology. And it is solely from that particular moment onward that you are able to commence practicing on your patients. All right? That could be the most crucial message.
Do not bypass any steps. If you desire to acquire a methodology that is highly effective, practical, secure, and most importantly, optimal, it is crucial to adhere to the steps in this specific sequence. Only after thoroughly completing these steps can you initiate your regional anesthesia with the assistance of ultrasound guidance.
Well, that's it. We're done. I hope you enjoyed the content. This is the first version, which inevitably contains some inaccuracies, but it will be enriched over time with links to examples, videos, or other topics as the practice evolves. As you have understood, this is not a complete almanac. There are many websites out there created by very brilliant experts, but this is the first time a pragmatic, concrete method is being offered to train others, who will themselves become trainers, in order to spread ALR to as many people as possible safely.